CTO PCI for mitral regurgitation, or I entitled it, "It's Not Just for Angina Anymore." As I mentioned, or Cal mentioned, I'm from the Minneapolis Heart Institute, and I don't have any relevant disclosures, unfortunately. The patient is a 57-year-old man with an interesting past medical history of HIV positivity, and he's had a PE while on Xarelto, and was treated with Xarelto. He suffered from recurrent episodes of flash pulmonary edema and presented to a different hospital than ours. On echocardiography, he had normal left ventricular function and mild mitral regurgitation. These are the images of his dobutamine stress echocardiogram, which I am assured shows that there's no obvious ischemic defect. At least this is what the echo people told me it shows, and I will believe them. This, however, is the dobutamine stress echo with color flow. Notice I noticed that this was a color flow Doppler study, and because they told me. And you can see that the mitral regurgitation becomes much worse with dobutamine. So the dobutamine stress echo showed worsening of mitral regurgitation, and they performed a coronary angiogram, and it showed surprisingly minimal disease in his LAD in the right coronary artery and the circumflex, but a complete or chronic total occlusion of his ramus intermedius. And at that outside hospital, PCI was attempted, but they were unfortunately unsuccessful. So the patient was referred to the MHI Center for Complex Coronary Intervention. So if you look at this angiogram here, you can see the ramus, and it looks like it's got a nice little channel. So I was chuckling to myself that the prior interventionalist's investment procedure probably paid off. So you can see it sort of coming in slowly there. So I just went straight in an antegrade with a Fielder XTA on a threader, assuming I was going to be able to get in pretty easily. Pictures later showed not being so sure that I was in, and in fact I wasn't in the true lumen, I was in a dissection. So we attempted the dissection reentry strategy with a Stingray. You can see that here, the wires exiting in the correct direction, probably continuing on through the other side of the vessel, so it's kind of going through and through, which is why in this in most situations a stick and swap is particularly helpful. But I wasn't sure about that, so we ended up needing to try to go retrograde. So here I used a ping pong technique, an XTR, and a turnpike LP to go retrograde. Ping pong, as I said, to externalize the wire. The wire, I was able to direct that directly, and then perform antegrade PTCA, and stents and more balloons were done, and this should be, there you go, after a little angioplasty, and we decided that this was going to be a satisfactory result. So we sent him back to his referring hospital, and a repeat dobutamine stress echo again showed no significant ischemia here, and what they assured me was no dramatic worsening of the mitral regurgitation with the dobutamine stress echo. I had to trust them on that because I wasn't quite as convinced. So I believe that's the first report of mitral regurgitation treated with CTO PCI that I'm aware of. I was trying to find some others in the literature. It's obviously an extremely isolated case.
It's awesome. Thank you so much. So there is no ischemia by stress test, but yet there is ischemic MR.
Yes.
How do you explain that?
Well, it depends upon how you define ischemia. And one is wall motion abnormality. There wasn't wall motion abnormality, but there was papillary muscle dysfunction.
So actually, it's a debate I often have with my boss, Richard Smalling, who's big into MitraClip. And you get these patients who have MR, and they have a CTO in that posterolateral branch or the OM2, which supplies the papillary muscle, and they have it. And he always wants to do the MitraClip, and obviously he always wins the debate. I think it's exactly that. I think the reason why acute MIs present with angina as opposed to the CTOs that present with dyspnea is because typically these patients have ischemic diastolic dysfunction, and that's what causes the EDP to go up. If the ischemia involves the distribution of the posterior papillary muscle, then sometimes even without wall motion abnormalities, you get a rise in EDP, worsening of MR, and I think that's the mechanism of the difference between the symptomatology of CTOs versus acute MIs, and that's why patients, their exercise and exertion capacity improves after ischemic MR.
Anybody else has any comments?
Well, the false negative rate of a stress echo is not negligible. It's 10%. And so you're going to miss some people on stress echo.
I'd say it's more like 25.
Yeah, the specificity is very good, but the sensitivity.
No, you've got to go with the clinical. And the guy kept on presenting with recurrent pulmonary edema, which was classic, and they weren't having any trouble diagnosing that. And this was the only reasonable explanation. And since that time, he's not been back in the hospital.
You know, I think this is like the Higgs particle. I know it exists. You're the first person to see it, so that's fantastic. Congratulations.
I think stress MRI sometimes can help you with this because you can actually see ischemia on the pap muscles or some scarring in the pap muscles, so that could help you guide therapy.
Absolutely. At the end of the day, we're going to have to make a clinical decision according to what we know as physicians. Like a test does not replace a clinical judgment. Absolutely.